on certain subjects. But for the most part, I did my best to follow your blueprint as best I could. So without further ado, we are going to start. So the first thing we are going to do is cover good old-fashioned module 1, which is really the basics of patho, the cell, fluid electrolyte imbalances, acid base, etc. It's important to note the different types of cellular adaptation, but where nursing gets different from your traditional anatomy and physiology is, well, what do these mean? Cellular adaptation, for example, hypertrophy. When is this a pathological issue? Well, it becomes a pathological issue when for example, if our heart has to work extra hard in cases of heart failure, which we'll talk about more in the cardiac portion, but you need to be able to recognize, not necessarily name the definition of hypertrophy, hyperplasia, metaplasia. You need to be able to identify what is occurring. It's important to note that with our dysplasia, it's got an increased risk for cancer. So what happens with dysplasia is these cells essentially form into an abnormal version of themselves. If anyone's ever heard of Barrett's esophagus, which you'll learn later on in your nursing program, really when our body sustains a good amount of damage, our body will try to, replicate new cells, but they aren't the same picture perfect cells. They are cancerous, essentially. So that's a good way for you guys to remember. Well, usually with dysplasia, this puts the patient at increased risk for cancer. So it's not necessarily about knowing the definition, but knowing more patho related. Everyone knows hyperplasia, increase in number of size. This can happen with our thyroid disorders that we'll talk about as well. So don't focus too much on the definition. Know how to identify what adaptation is occurring, and that's going to help you a lot because you're going to be expected to, you'll be given a scenario and you'll need to figure out what's going on, what adaptation is going on. Up next, we've got good old-fashioned genetics. So when we're talking about our karyotype, this really is the complete set of chromosomes in nice, perfect order, going 1 through 22. This is really important when we start to talk about different pathologies, which I think you'll get to a little bit more in the second half of your pathophysiology. For example, more so your trisomy 21, trisomies, phenotypes, etc. It's important to note the difference between homozygous and heterozygous. The reason that we need to know these is because lots of our pathologies, especially when you get to pediatrics of nursing, a lot of our pathologies are involving variations in our genotype. Phenotype is what we physically see. For example, red hair. The phenotype for someone with Turner syndrome is usually the webbing of the neck. However, the genotype, the girls are missing or have a deformed X chromosome. So their genotype will be X, but what we physically see is more of these alterations. A couple different chromosome aberrations you should know. We're talking about polyploidy versus aneuploidy. Polyploidy is incompatible with life, okay? Meaning they have more than one set of chromosomes. This is an issue because the body is really unable to sustain life. These will often present with stillbirths or abortions later on during pregnancy. They're called spontaneous abortions. They are incompatible with life. However, our aneuploidy, think abnormal, like trisomy 21. They simply have an extra chromosome. They don't have an extra pair, they just have an extra chromosome. These will end in somy, such as monosomy and trisomy, like trisomy 18, Edwards syndrome. This is compatible with life. However, these kiddos and patients are going to require a little bit extra care We're talking about gene disorders. Everyone knows Mendel's P's and Mendel's P's project. This is important when we start talking about our Huntington's disease and other neuro disorders. We need to know what is the inheritance, especially when you get to your hematology section. A lot of our hematological disorders are autosomal dominant. So a dominant trait, these are a lot easier to inherit. As you can see, if the dad has the condition but the mom does not, you have a 50% chance of inheriting that condition. However, in autosomal recessive, you need both, for example, little r's to present this trait. However, with an autosomal recessive disorder, it's not common to present, but it's very common to be a carrier. Alrighty. When we're talking about our innate versus adaptive immunity, our natural immunity, this is our cellular level and our physical level. So physically, we have barriers such as our skin, our mucous membranes. If I get, let's say, scratched by a stick because I'm hiking outside, my body's going to produce inflammation. That is all an innate natural process. We see these granulocytes, natural killer cells, mast cells. Remember, our innate natural immunity is non-specific. It is going to produce the same response to any pathogen every time, whether I cut my leg with glass or I cut my leg with a rusty knife, it's going to produce the same response. Inflammation and fever are part of our innate and natural response. Our acquired or adaptive immune system, this is highly specific. So our response is tailored to a specific pathogen, and thus we will produce our B and T cells that have memory. These will produce antibodies with memory to remember the specific response. Phagocytosis is part of our innate immunity, but just note that with phagocytosis, they essentially consume the pathogen, okay? It's not a specific pathogen, it's whatever the body deems as a pathogen. The steps of phagocytosis include recognizing and adhering to the target, engulfing it, fusing, and essentially making little granules that will decompose and become really, really tiny so that it can be destroyed. As I said earlier, inflammation and fever are part of our innate immunity. Remember, when we're talking about fever, fever is systemic, heat is localized. Inflammation has heat involved. It's redness, heat, swelling, and pain. Both are part of our innate immunity, but just please remember that fever is systemic, heat is localized. And I've also listed the steps for you. Now we get to talk about our adaptive immunity. I like to use the acronym GAME DAY, G-A-M-E-D, for Game Day. We talk about G, it's at the top of the list, meaning it is the most abundant. Our A, this is usually found in our mucosal membranes. M, I want you to note that M is the first antibody produced to fight a new infection. So if I get my patient's CBC back and they have high amounts of IgM, immunoglobulin M, I know that this infection is pretty new, okay? Once the body recognizes this got an infection, and if my patient has an infection later on, obviously they're going to have IgG. They're going to have more IgG than they will M. But M lets me, the nurse, know that my patient has a very recent, very new infection. E, I want you to think allergies. IgE is associated with allergic reactions. And finally, D, it exists in small amounts. It's really the least understood. When we're talking about transplant reactions, this is an autoimmune innate response to whatever the body recognizes as foreign. We'll talk a little bit more about autoimmune diseases towards the end of this lecture. But to note that with transplant reactions, we've got our hyperacute, acute, and chronic. Hyperacute, we need to get that kidney out, or if they had a liver, we need to get that out. They will have very, very quick fever and pain, and lots of symptoms within the first 24 hours. When we move to our acute phase, this is usually first 6-ish months, and you'll slowly start to see the patient's body temperature arise. You'll start to see something going on with them. This photo is specific to the kidneys, but it's just easier, I think, to kind of think about it in a pathology term. Okay, he got a new kidney. Well, if he's symptomatic within 24 hours, that's our hyperacute. If he's symptomatic within the first couple months, that's acute. Now, chronic rejection, you will see slowly happening. However, I want you to note that with the acute and the chronic, our focus is going to be on immunosuppressants. You'll learn more in pharmacology about immunosuppressants and corticosteroids, but both of which suppress the immune system in an effort to suppress the autoimmune reaction, the transplant reaction. It's really, really important to know that if your patient is on an immunosuppressant medication, they are at increased risk for infection. So you're going to teach them not only to take their medications, but to be safe. Don't go out in large crowds. Wash your hands, thoroughly wash your fruits and vegetables, etc. As I said, autoimmunity is ourself. Our body, for whatever reason, is recognizing something as a foreign object that it shouldn't. Okay. We'll talk about SLE, rheumatoid arthritis later on in the nursing program, but just keep in mind that with autoimmune diseases, they are all always characterized by exacerbations and remissions. Well, what is going to cause an exacerbation? Stress. I teach every single one of my students, my body does not know if I'm stressed from nursing school, or I'm stressed because I'm starting a new job, or I just ran a half marathon. The body simply doesn't know. It just recognizes stress as stress. So it's really important for our patients with autoimmune issues that we reduce stress. HIV and AIDS. AIDS can only occur in an individual with an HIV infection. Now we'll talk about HIV in Complex Health 1. You've probably heard about it, learned about it a little bit in Patho. Really, it's just important to note that without treatment, HIV can progress to AIDS. And what happens with AIDS is my body's CD4 count. Remember a few slides ago, our CD4 cells, those are our immune cells. The CD4 count gets so low that my body will not be able to fight any sort of infection. Therefore, my patients are at risk for all of these opportunistic infections and rare cancers, such as Kaposi sarcoma, hairy oral leukopenia, to name a few. They're at risk for cytomegalovirus. All these crazy diseases we don't really see often. Why? Because we have healthy immune systems. Without treatment, it usually takes about 5 to 10 years to progress to AIDS. But with treatment, they can live a relatively normal, happy, and healthy life. All right, now we're going to head into module 2, which is more of our fluid and electrolytes. It's quite easy to know the differences between fluid volume deficit and fluid volume overload. But I really want you guys to be focusing on fluid volume overload, because right now in pathophysiology, you will see fluid volume overload or fluid volume excess in 2 pathologies. You will see them in SIADH, and you will see them in heart failure. So it's really important, I think, to know what we see in a patient with fluid volume excess. Usually these patients will have low sodium because we have so much water. Our salt to water ratio is thrown off. And when you think salt, I want you to think seizures, salty seizures. Any issues with our salt balance puts the patient at risk for seizures. Therefore, a patient who has fluid volume excess will be on seizure precautions, which you have learned about in fundamentals, or you should be learning about in fundamentals soon. Obviously, we're going to see high blood pressure, bounding pulse, lots of weight gain, edema, pitting edema, and whatnot. Fluid volume deficit, this is more of our dehydration. So usually they're going to be restless, lethargic, weak. Our heart rate's going to go up. Why? Because usually the blood pressure is low when we are dehydrated and our heart's trying to compensate, and all of those good things. Speaking of sodium imbalances, remember hyponatremia, less than 135, hypernatremia, greater than 145. It's important to note these lab values. They will show up a lot throughout your time in the program. Again, salty seizures. But one thing to note, I always say this, where salt goes, water flows. So if someone is holding on to a lot of salt, they are going to hold on to a lot of water, okay? So when someone has hypernatremia, they will be big and bloated. And it can be a little bit confusing sometimes because we think, oh, well, with hyponatremia, well, heart failure can cause hyponatremia, or SIADH can cause hyponatremia, but that doesn't make sense because usually if there's lots of water, there's lots of salt. Well, heart failure and SIADH are a pathophysiology. So naturally things are going to be a little bit different. But if the only thing that is wrong with your patient is the salt imbalances, if they have lots of salt, salt sucks. Where salt goes, water flows. They're going to hold on to water. We're just right now talking about electrolyte imbalances. Potassium, we love potassium. Why? Potassium pumps the heart. If you have any sort of issue with potassium, our heart is going to be affected. When you think hypo, think low. They're going to have hyporeflexia, nausea, vomiting, paresthesias, etc. If we have hyperkalemia, things are getting a little high. They're getting a little bit crazy. These patients are going to have increased deep tendon reflexes, and you're going to see lots and lots of EKG changes. Not fun at all. Potassium imbalances are life-threatening. Please watch the cardiac monitor closely. We never give potassium IV push, IM, or SQ. It's very, very painful. We will put it in an IV and we will dilute it with normal saline. Up next, we get to talk about ABGs. If anyone is really struggling with ABGs, please meet with me privately. I have a whole section where I go over ABGs, and I've got lots of practice questions we can do, but right now this is just an overview of ABGs. This is not a pump and dump thing. ABGs will show up throughout the entirety of your program, so it's important you get a nice, good, fundamental base with it. So when we talk about pH, please memorize your normals like the back of your hand. You will be expected to memorize these. Normal pH is 7.35 to 7.45. PaCO2, carbon dioxide. Carbon dioxide is an acid. Please remember that. Our normal value is 35 to 45. If I have a PaCO2 of 77, that's a lot of acid, so it's going to be acidic. HCO3, that is bicarb. Bicarbonate, bicarb. So I know it's a little bit confusing, HCO3, but it is bicarb. And we think bicarb, think basic. Bicarb is basic. Our normal value is 22 to 26. If I have a bicarb of 54, my pH is going to be pretty high, meaning it's going to be basic. I know it gets a little bit confused, but the higher up we are, the closer we are to 14, we are basic. Even though it's a high pH, that means basic. When we're talking about acidosis, we can have metabolic versus respiratory. So with a metabolic problem, when we think metabolism, think kidneys. That's where all of this stuff happens. The kidneys help with producing bicarb. So if someone has metabolic acidosis, it means that they don't have enough bicarb. And they're holding on to way too much hydrogen. Therefore, my lungs will try to compensate by blowing off CO2. But remember, metabolic, they'll move in the same direction. So my bicarb will be low, and my pH will also be low. We're talking about respiratory acidosis. Well, like I just said, CO2, we hold on to CO2. CO2 is an acid. So if I have a high CO2, I will have a low pH. My pH will be more acidic. I have on the bottom my little tips tip. An abnormality in the bicarb will indicate a metabolic problem. An abnormality in the CO2 level will indicate a respiratory problem. It's always important to, first things first, always identify your pH. Is it acidotic or is it alkalotic? With metabolic alkalosis, my bicarb will be really, 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 really high. They move in the same direction, usually caused by vomiting, diuretics, antacids, things like that. Respiratory, usually hyperventilation is our most common cause of alkalosis. The CO2 is essentially less than normal. They're breathing out way too fast. They're not holding in any acid. This will switch us to an alkalotic state. Now we get to talk about the brain. I love the brain. I'm an RN on the neuro floor where I work, and I think the brain is very, very fun. So yeah, I made this little slide for you guys, but I would just want you to note that our pituitary gland is very finicky. Due to its location, if we have any sort of increase in ICP, which I'll talk about later in the neuro part, this can lead to pituitary gland dysfunction. The main issues we see with the pituitary gland is SIADH and diabetes insipidus. However, the pituitary gland, there's a couple other glands. We've got our thyroid stimulating hormone, we've got ACTH, and whatnot. Don't worry too much about this slide. I break it down. I just thought this will give you kind of an overview of just how important our brain is. So we have hypo, everything is low. When we have hyper, everything is high. Again, please don't stress about knowing everything on this slide. I'm gonna break it down for you guys. So when we're talking about SIADH, we have way too much ADH hormone being produced. So remember what I said, brain tumors, increased ICP, anything like that can affect the pituitary gland. Well, what is SIADH? What is ADH? ADH is antidiuretic hormone, meaning anti-pee hormone. So if you have a hormone in your body that is telling you don't pee, don't pee, don't pee, what are you going to do? You're going to hold on to all that water. It specifically tells the kidneys not to release urine. But as the brain keeps producing more and more ADH, the body is going to hold on to more and more water. So your patients will have massive weight gain pretty darn rapidly. They're going to have very concentrated urine as well. And they're not going to be having a lot of output either. However, our main concern with the fluid retention, not only is that putting excess pressure on our organs via the increase in blood pressure, it is also changing our salt balance. And like I said, salty seizures. So we are really, really concerned with SIADH. How is this treated? Don't worry too much about treatment. What we're going to do is we're going to restrict this patient's fluids, and we're going to give diuretics to get the fluids off, and we're going to treat the underlying cause. Diabetes insipidus, think dry inside. This is not related to diabetes mellitus at all. But essentially why it's called diabetes insipidus is because it's leading to polyuria and polydipsia, which are one of the first signs and symptoms of someone with undiagnosed type 1 diabetes. That's the only reason it's called diabetes insipidus. Because the polyuria and polydipsia, they're peeing a lot and they're very, 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 very thirsty. It can either be a problem with the brain or the kidneys. We're going to focus on neurogenic. But essentially, the body does not have enough ADH, so my kidneys are just getting rid of all the water that we take in. The treatment for this is going to be giving vasopressin therapy and rehydrating them. It's really important that what goes out goes back in. If your patient just peed out 2 liters of fluid, we're going to give them 2 liters of fluid. Now we get to talk about diabetes. I think we're all pretty familiar with diabetes, but I have had students before that just aren't familiar with it. So I thought I'd break it down. Type 1 diabetes, this is autoimmune related. So please remember autoimmune. The body does not secrete insulin anymore. So we are going to give it what it's missing. We're going to give them insulin. The reason we give insulin is because we're trying to prevent complications such as DKA, which don't worry about yet. Type 2 diabetes, on the other hand, this is more of a glucose insensitivity issue. This is caused by lifestyle issues, such as obesity, the metabolic syndrome, etc. For type 2 diabetes, instead of treating with like medications and stuff, we're going to focus on lifestyle changes such as diet and exercise, and metformin, or an oral hypoglycemic drug. We do not, in NCLEX world, treat type 2 diabetes with insulin, but you might see that in the practice. But in NCLEX world, we don't treat type 2 with insulin.
Can you hear me?
Yes.
Can you possibly slow down just a little bit so we can write some things down?
Oh yeah, of course. No problem.
Thank you.
Yeah. But yeah, so with type 1 diabetes, just note that it's autoimmune related. The body simply cannot produce insulin. I have like a little tutoring Instagram I can pop in the chat where I like draw things out on whiteboards and stuff. But essentially what happens is insulin is a lock and key. Insulin allows my body to take sugar from the bloodstream and store it inside, if you will, usually in like andisposed tissue or in the cell. Insulin is our lock that opens the door. If the body does not have insulin, all the sugar builds up in the bloodstream, and that's not good. With type 2 diabetes, we still have insulin, but my body just gets so used to having high amounts of sugar in the bloodstream, it's not going to produce as much insulin because my body's like, well, just a normal Monday, just a normal Tuesday. That's why we focus on diet and exercise for this patient. Here's another little thingy I drew out to help you guys understand thyroid disorders. When you guys think of thyroid, I want you to think energy. T3 and T4 are our thyroid hormones. Our thyroid hormones think energy. If I have too much thyroid hormone, I'm going to have lots of energy. If I don't have enough thyroid hormone, I'm not going to have a lot of energy. And that's a good way that you can kind of remember thyroid disorders. Remember, the brain is still involved. So if we have any issues with our brain, we might see some issues with our thyroid. But essentially what happens is my brain is like, I need some energy. So what am I going to do? I'm going to produce thyroid stimulating hormone, TSH. What TSH does, I want you to think of a dartboard and a dart. If we need more points, if we need more energy, the body is going to start producing TSH, which is going to essentially hit and act on the thyroid. So the more my thyroid gets hit by thyroid stimulating hormone, the more points on my dartboard I'm going to rack up, the more points, the more energy I'm going to have. So if my body senses, I need some more energy, it's going to produce more TSH. Keep this in mind when we talk about some pathologies. We're talking about hypothyroidism. I simply don't have enough T3 and T4. Why do I not have enough T3 and T4? Well, either A, my brain is not producing thyroid stimulating hormone to act on the thyroid, or I simply am having an issue where my thyroid, no matter how much TSH I produce, my thyroid's just not giving me T3 and T4. It's not important to know the nitty-gritty patho of that at this point in your nursing career. I just focus on understanding the signs and symptoms. So think low and slow. slow metabolism, they're very cold, they're very tired, brittle nails, weight gain is really common. They're going to be cold a lot, very achy. Talking about hyperthyroidism, think sped up. I've got so much T3 and T4. I've got so much energy. People talk about Graves' disease. That's more the antibody related process, but sometimes patients just have hyperthyroidism where their body, for whatever reason, produces way too much TSH, thyroid stimulating hormone, or the thyroid is just going a little bit out of whack. Again, not super important to know that piece of it. I would just note at recognizing these signs and symptoms. Obviously, with hyperthyroidism in their blood count, you're going to see lots of T3 and T4. They're going to have a very high metabolism. They're going to probably require about anywhere, I would say, between 3,000 and 5,000 calories a day, just because their metabolism is so sped up. They're going to have a lot of weight loss, high blood pressure, everything is sped up. The GI tract is sped up. Heart rate is sped up. Blood pressure is sped up. So just keep that in mind. All right. When we talk about the parathyroid hormone, it can be a little bit confusing, but I just want you to know PTH, parathyroid hormone, pulls calcium into the blood from the bones. So a lot of people don't recognize that. Where does all this calcium come from? Well, yes, calcium comes from the diet, but it goes to the bones. If my body needs calcium for whatever reason, and it needs it in the bloodstream because let's say my calcium levels are low, what's my body going to do? Well, the body's pretty cool. It's going to try to compensate, but it's going to pull it from the bones. So let's talk about it. Hypoparathyroidism, they don't have enough parathyroid hormone. This is going to result in hypocalcemia, a low calcium count in their blood. When you get a CBC on these patients and you get a basic electrolyte panel, remember, calcium should be between 9 and 11. So a patient with hypoparathyroidism is probably going to have a calcium more like 5 or maybe 6. That is when you're going to see, please keep these in mind. These will help you out in nursing fundamentals, the Trousseau sign and the Chauvet sign. So Trousseau sign happens with hypocalcemia when you put the blood pressure cuff on their arm and they have a hand spasm. Chauvet sign, think cheek. When you stroke the cranial nerve in the cheek, they're going to twitch. When you stroke the facial nerve, they're going to twitch. Their cheek will twitch. So think Chauvet, think cheek. Hyperparathyroidism, I got lots of parathyroid hormones. So what is it going to do? It's going to pull lots of calcium into the blood from the bones. This is an issue because it's going to keep pulling calcium from the bones. And then guess what's going to happen? It's going to make the bones very, very weak and brittle. In addition to that, it is going to bump up the serum calcium levels to probably maybe 14 or 15, and that's going to put the patient at risk for dysrhythmias. A little fun farm fact, one of our cardiac medications we give is called calcium channel blockers. Calcium is also an important electrolyte when it comes to cardiac electrical activity. So I also want you to note that issues with calcium can also negatively affect the heart. All right. When we're talking about Cushing's versus Addison's, Addison's is really an issue because we can have this massive hypotension, which eventually leads to vascular collapse and shock. When we think about our adrenals, remember everything does come from the brain. The brain will secrete hormones that can act on your adrenal glands. So don't think that it's just like an adrenal issue. Remember, the adrenal glands are on top of the kidneys. But with Addison's disease, we have too little cortisol and aldosterone. Remember, aldosterone is part of our RAS system, renin-angiotensin. system. So if we don't have enough cortisol and we don't have enough aldosterone, we're going to have low blood pressure. This is going to contribute to weakness, weight loss, and other issues. Our Addisonian crisis, this is severe hypotension. Cushing's, on the other hand, this is way too much cortisol. So they're going to have that truncal obesity, moon face, buffalo hump, glucose intolerance, and protein issues. The pharmacology, or maybe the pharmacological reason that this happens, is abruptly stopping steroid medications or using too much steroid medication. So just keep that in mind. It's bound to show up through the remainder of your program and here. When we specifically have Cushing's disease, this is the non-pharm reason why Cushing's happens. My body just secretes way too much ACTH to produce more cortisol. Alrighty, module 3. So this is more of our respiratory module. I did my best to talk and add in as much as I could with what I was given. And we're talking about epiglottitis. This is usually caused by a Hib infection. Please, 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 please note the hallmark signs and symptoms and what not to do. They will have a muffled frog voice. They will be drooling and they will be tripoding. The reason they are doing this is because the epiglottis is kind of swelling and constricting the airway. You should never examine the throat if your patient is having this muffled froggy voice and you note in their history they had a recent bacterial infection or a recent influenza infection. We're not putting anything in their mouth. No tongue blade, no nothing. This one is a mouthful. When we're having acute laryngotracheal bronchitis, this is when we have essentially inflammation of everything. Usually these are caused by viruses and rubella, but they do essentially run its course. When someone has recurrent, they are going to have less inflammation and it's going to resolve a little bit more quickly. However, this is more, how do I put this? Pathology related as opposed to a viral infection. This is when we'll see that harsh seal-like barking cough. One thing to note, and I'll try to guide you guys a little bit, and I'll let you know. But really what we're talking about in this slide and the slide before, a lot of these are very common in pediatrics. So please keep that in mind because it will show back up in your Women, Children, Family course. But in maybe practice questions you'll find and whatnot, a lot of it's going to be pediatric related because these are more common in pediatrics. I'll let you know when we get to more of our adult respiratory issues. I would also note that if your patient is presenting with deep retractions, stridor, agitation, altered level of consciousness, we're having an airway emergency and we need to intervene. All right, just some more respiratory disorders. Allergic rhinitis. This is when we as nurses advise the patients to avoid their triggers. Essentially, they're having lots of runny nose, sinus swelling, etc. because of allergies, most often treated with Benadryl. At this point in your program, just focus on teaching the patient to avoid their triggers and to keep an allergy log. Laryngitis. These patients will often have lots of pain and a sore throat at night, usually often preceded by RSV, again, more common in our kiddos. But remember, with kiddos, our care is going to be more supportive, so mist vapors help a lot. For influenza, you've learned about your different types of precautions in your fundamentals course. That's more so what we're concerned about with influenza, not much treatments. It's more advising the patients to get their flu shot every year, making sure that they're placed in a room by themselves. There's an asterisk next to this. The only time that we would not put them in a room by themselves is if the hospital is full and there is someone that also has an active flu infection. You can put them in the same room. But for the most part, they're going to be in a room by themselves, and you wear a mask within 6 feet under droplet precautions for these patients. Now we get to talk about pneumonia. This is why we get our patients up to chair, up out of bed, OOB. It's why we're telling them to use their incentive spirometer, because there's lots of different types: community-acquired pneumonia, hospital-acquired pneumonia, ventilator-acquired pneumonia, etc. But what happens with pneumonia is we get infected secretions that settle in the bottom of the lungs, and this impairs breathing. They're not able to take as big of a deep breath in or out. Therefore, we will see some acute changes in LOC. Whenever you see an altered level of consciousness, I think of two things. I think of brain issue, whether it be increased ICP, seizures, whatnot, or I think inadequate oxygenation. So you ever see an acute change in level of consciousness, like your patient was talking to you and now all of a sudden they're combative, they don't know where they are, put a pulse ox on them. Okay, put a pulse ox on them. What is their O2 sats? How are they satting? And that can give you a good picture of what's happening. All right, up next is asthma. We focus a lot on asthma in Complex Health 1, where we talk about inhalers and whatnot. We're not there yet, but this is the patho behind it. So we have a hyperreactiveness, hyperresponsiveness to a trigger, whether it be perfume, whether it be allergies, whether it be exercise, that essentially causes my airways to swell and become constricted. Okay. These patients will have wheezing and shortness of breath. It's very important that if we know our patient has asthma and they were wheezing, well, what happens if I'm assessing my patient, he's wheezing, I go, I grab something, I come back, I listen to him again, and he's no longer wheezing. That is very, very bad, okay? That means that the airway has become so constricted, we're not hearing that wheezing anymore, because we hear wheezing when air is trying to get around the constriction. If we no longer hear wheezing, that's a concern, and we're going to immediately report that to the provider. This treatment with albuterol, a short-acting beta agonist, which is going to open up the airway. Now we're going to head into our adult issues, just for a little bit, because then we're going to flip back to peds. But COPD, obviously, biggest risk factors, smoking and tobacco. It's going to be common. It is common in our adult population. It's comprised of chronic bronchitis and emphysema. So with chronic bronchitis, we got lots of inflammation and lots of mucus in the bronchioles. Emphysema, my lungs. My lungs have no recoil. They're not elastic anymore. My alveoli aren't going to spring open and shut close anymore. So with the chronic bronchitis, they're going to have a frequent cough, mucousy cough. With the emphysema, you're going to see more that widened rib cage, lung issues, etc. Cystic fibrosis, flipping it back to our pediatrics. This is an autosomal recessive disorder, which is why it's not very common. However, this is quite severe and it does require lots of nursing care. These patients are going to have thick, salty secretions in their mucus that's going to get stuck. They're going to require lots of chest physiotherapy, some medications that help with the mucus and whatnot. But for our purposes, we really need to recognize our symptoms. They're going to have wheezing, lots of sputum, barrel chest, clubbing of the fingers, and salty skin. Pleural effusion, again, we more so see this in the adults. Just note that as fluid begins to build in the pleural space, it's going to squish the lung. Because this fluid will not be drained by our normal lymphatic system, we're probably going to need to put in a chest tube or do like a needle aspiration or something like that. It's important to note our hallmark signs and symptoms. These patients are going to have lots of pain on inhalation, shortness of breath, and let's say we auscultate their left side of their lungs and their right side of their lungs. Well, if I go all the way down the back and I'm on the left and everything was normal, I heard everything. I went to the right. As I'm going down my back, I stop hearing sounds. That's diminished breath sounds. That means that there's fluid building up in the area and I can't hear the sounds because there's fluid in the way. Additionally, if it gets very bad, the trachea will deviate to the unaffected side. So usually our trachea in our neck is midline, it's in the middle. With the pleural effusion, if you see the trachea more so on the left side, that means that the pleural effusion is going to be on my right side, which would make sense if I was hearing those diminished breath sounds on my right. Pneumothorax, again, common in our older adults. We see this a lot in trauma, more so rib fractures, bullet wounds, stabs, etc. But essentially what happens is air gets stuck and that air will squish the lung. So we talked about, like our slide earlier, about our pleural effusion, that was fluid. With our pneumothorax, this is air putting lots of pressure on the lungs. This is when you'll see like in like trauma shows like Grey's Anatomy, where they'll take like the foil square and they'll tape down 3 sides. That's what we do for like a pneumothorax or a chest lung. Not super important now, but this is like the highly, this is what everyone will have on any sort of medical show, if you will. More important to know the clinical manifestations, they'll have lots of pleuritic pain, which is lung pain, tachypnea, and dyspnea, which is shortness of breath. Tachypnea is an increased respiratory rate. Alrighty. Up next, we have atelectasis. Remember the function of our little alveoli? What our alveoli do essentially is they're the site of gas exchange. So they're going to take that CO2 and exchange it for the oxygen so that we can oxygenate our blood. Our blood can go throughout the body, oxygenate our organs, etc. What happens with atelectasis is my alveoli become deflated. And when they become deflated, they're not going to do their job as well. So these patients again will present with dyspnea, cough, fever, and leukocytosis, especially if it's more so of an infection. This is why we get our patients out of bed. This is why we whip out that incentive spirometer. That's why we do all of that, because we're trying to prevent ARDS and ARF. So ARDS, what happens with that infection, all that yucky gunk deposits in my alveoli. As it deposits in the alveoli, I simply will have no more room left for gas exchange. Why? Because my alveoli can't fill with blood to filter the oxygen because they're filled with pus and gunk. This puts my patient in acute respiratory distress syndrome. They're going to have some pulmonary edema, some shortness of breath, increased work of breathing. You'll start to see your patient trend in the negative direction. If we leave ARDS untreated, they will progress to ARF, acute respiratory failure. This is when we give my patient 100% oxygen via non-rebreather mask, and their O2 sats just keep getting worse. Why? All their little alveoli filled up with pus. They cannot filter blood anymore. This will lead to acute respiratory failure, which will require mechanical ventilation in an effort to pop open those alveoli and do alveoli recruitment. So remember, ARF and ARDS kind of go hand in hand. If we do not help out with ARDS, your patient will progress to acute respiratory failure and will need mechanical ventilation. Now we get to talk about the heart. Everyone loves the heart. I know this was later on in your blueprint, but I thought that I would put this here just to kind of get it out of the way. When we're talking about myocardial ischemia, this is when my heart receives inadequate oxygen. Okay. However, myocardial ischemia can come and go and it can be reversible. Remember, this ischemia, think inadequate oxygen. We're talking about a myocardial infarction. This is actual tissue death. This happens if someone's having a heart attack and it is left untreated. Or when someone is having an active heart attack as opposed to unstable angina, which we will get to, we will talk about it. But please note that with a myocardial infarction, these patients are usually more symptomatic, and they are, if we do not get them treatment within an hour, we will have permanent tissue death and damage within the heart, which puts them at an increased risk for heart failure. All right, pericarditis. This is pleuritic pain caused by inflammation of our outer sac of the heart. However, what's interesting about this pain, and this is how we really differentiate pericarditis from some other cardiac issues, is that the patient's pain will be relieved if they sit up and lean forward. We don't really see that with anything else, like with heart attacks and whatnot. But essentially with the pericarditis, when we have acute pericarditis, we're going to see those EKG changes. However, chronic, we're not going to see the EKG changes, but it puts them at increased risk for heart failure. Remember, what we are a little bit concerned about with pericarditis is a pericardial effusion. If we let pericarditis go without treatment, well, remember, kind of part of the body's inflammatory response is to release those cytokines, to release swelling, to release inflammation. Well, the cytokines can come, capillaries become leaky, and then boom, that pericardial sac can now begin to fill with fluid. Therefore, they're still going to have that dyspnea, edema, and chest pain. So it's very important we treat these patients. And how do we treat them? Well, what's the underlying cause of the inflammation? Is it an infection? What's going on? They might, with the pericardial effusion, require a window, or essentially they'll stick a needle in the sac and drain it. All right, infective endocarditis. This is actually pretty interesting, often preceded by a strep or staph infection. The body kind of goes crazy. The body panics and essentially releases lots of clotting factors in the body with infective endocarditis. Therefore, we will see petechiae, which is like red pinpoint rash. These patients will have Roth spots. They will have splinter hemorrhages on their nails. If you look at their nail, you will see a red line down the middle. That's a splinter hemorrhage. They'll have a new murmur. Really, our main concern is blood clots, because guess what? Now we're at risk for DVT. Now we're at risk for an emboli, etc. Roth spots are those red little dots you'll actually see on their eyes. So we talked about pericarditis. As you can see, pericarditis was more pain-related. Endocarditis, we're having a clotting issue, and that's a way that you can kind of remember them, because I know people can get a little bit confused. You've got pericarditis versus endocarditis. Pericarditis, think pain. Endocarditis is more of our emboli. Okay. How do we fix this? We treat it with antibiotics through a PICC line because they're probably going to need months worth of antibiotics. Myocarditis, this is inflammation of the muscular issue. However, our main concern with myocarditis is this can put my patient in acute heart failure. If my muscle is inflamed and swollen, it can't squeeze as effectively. Okay, therefore, myocarditis, we want to be kind of cognizant of what are our interventions for a patient with heart failure. Well, it's not important to know what drugs we're going to give them yet. I just called it the cardiac drug cocktail. And heart healthy supportive measures, which we've learned about: low salt, fluid restrictions, rest, etc. Alrighty, this seems like everyone's favorite. Every semester I teach valve disorders. I really wanted to break it down super easy for you guys. But essentially we've got stenosis and we've got regurgitation. Stenosis, blood flow is impeded. Regurgitation, we've got backward leakage. Okay. The treatment for stenosis is going to be valve replacement. We can have our mechanical versus biological valves. Note that these patients will require antiplatelet therapy. Don't stress too much about our sounds. I just listed them here for you now because this will show up throughout your program. What are you hearing, etc. With our regurgitation, we've got our backward leakage, so our treatment is going to be more of a valvuloplasty. Again, I listed these sounds for you guys, where you're going to hear them. You learned a little bit in health assessment, how to auscultate. We have All People Enjoy Time magazine. We're in the second intercostal space, right of the sternal border. So we're going to hear aortic valve stenosis. So again, these sounds are here for you guys. All right, but to focus on one of them, we're going to focus on mitral stenosis, just to kind of reinforce the concept a little bit. But essentially, my valve is thick, stiff, and narrow, thus preventing blood flow. Specifically with mitral stenosis, I would note that this is often patients that have had a history of rheumatic fever often will present with mitral valve stenosis. Mitral valve prolapse syndrome, on the other hand, recurs with regurgitation. Therefore, you will hear an irregular heartbeat, palpitations, and dyspnea. You'll have that dyspnea because it is going to end up, The reason that they have dyspnea with mitral valve prolapse syndrome is because if blood cannot travel through the left side of the heart and it keeps getting backed up, it keeps getting regurged, it will get backed up into the lungs, thus leading to left heart symptoms. So think lungs. All right. They have a really great video on osmosis that goes over cardiomyopathies, because I think cardiomyopathy can be one of the more difficult topics to understand, and there's a lot to it. What I really want you guys to note is the pathology, what's in the middle. Don't focus too much on the etiology, maybe pick one or two, but really cardiomyopathy. Cardio meaning heart, myopathy meaning big muscular. What happens with cardiomyopathy is that the heart essentially is overworked. By whatever cause, it becomes overworked. When it's overworked, it's going to gain muscle. If I go every day of my life to the gym and I do bicep curls, really, really heavy bicep curls, my biceps are going to be really, really big. But what happens the day after working out your biceps? Your arms feel like jello. They're tired. You don't want to walk. You don't want to pick anything up. It's hard to swing your arms. That's what happens with cardiomyopathy, is that my heart has had to work extra hard. It's become thick, stiff, and rigid. It doesn't want to work anymore. It doesn't want to pump anymore. This is why cardiomyopathy is often a precursor to heart failure. And that is what I want you guys to know, that cardiomyopathy is a precursor to heart failure. And depending on which type, it kind of gives us a little bit of a better idea of the cause and what we might see. Like with hypertrophic, we'll see some diastolic issues as well as restrictive. Meanwhile, our dilated will be systolic. But aside from those little things and what you might have learned in class, really big picture, cardiomyopathy will lead to heart failure in a way. So what are we going to see with heart failure? We got left-sided heart failure versus right-sided heart failure. If you think of where the blood is coming from, the blood goes through my body, delivered oxygen to all of my tissues. Now it's time to get back up to the lungs to be oxygenated by our little alveoli. So with the right side of my heart receives blood from my body. Therefore, if there is any issue with the right side of my heart, it's going to cause a traffic jam. It's going to get pushed back into the right side of my body. Therefore, my body is going to have lots of symptoms of fluid volume overload. So you're going to see the dependent edema, JVD, enlarged liver, fatigue, and lots of weight gain, lots of edema, and whatnot. That's what we see with right-sided heart failure. I want you to think rocks the body with fluid. Why? The right side of the heart receives blood from the body. If the right side of my heart can't work and cannot pump effectively, traffic jam, it's going to get pushed back to wherever it came from. Similarly, with the left side of the heart, if the left side of the heart receives oxygenated blood from the lungs, if there's any issue with the left side of my heart, it is going to be backed up into the lungs. So think drowning in lung fluid. Left, think lungs. You will have some pulmonary edema, some crack folds, pink frothy sputum, orthopnea, nocturnal dyspnea, etc. What we see more commonly is a patient with left-sided heart failure. It will progress to right-sided heart failure. So you very rarely see right-sided heart failure on its own. Usually they have a right and left-sided heart failure just because of the patho behind it. If the left isn't working, it's going to get pushed back into the lungs, which is going to get pushed back into the right side of the heart, which causes the right side of the heart to have to work extra hard, because now not only is it trying to pump blood through, but it's getting this pushback. That's why it's really common that left-sided heart failure will lead to right-sided heart failure. This is another slide for more of our visual learners, what they're going to see with right-sided heart failure versus left-sided heart failure. So I just thought I would add that in for you guys if you want me to take a few moments and just kind of look at these signs and symptoms. We really got our lung, we've got it's essentially just lungs versus body. I'll give you guys a few more seconds just to look over it. Alrighty, now we get to talk about aneurysms. Right now we're going to talk about the aneurysms that happen on our aorta, heart, cardiology, whatnot. When we get to our neuro, we'll talk about our brain aneurysms. But essentially, aneurysm is an outpouching. Okay, it's an outpouching. The issue with this outpouching is that, remember what our aorta does. Our aorta delivers blood to the body. Okay, it goes down the aorta, splits into the femorals, but it's an artery. What happens with aneurysms? We got an outpouching. Well, if we have an outpouching, we're concerned that that outpouch is going to burst. If an artery bursts, blood will no longer be in systemic circulation. It'll now be like going in between the tissues, depositing at the bottom, whatever. It's not going to be in systemic circulation anymore. Meaning, if your patient has a ruptured aneurysm, you're going to see a drastic drop in blood pressure. They were probably 140 over 90, and then they're like, man, I'm having really, really bad pain right now, like ripping, tearing pain. And you check their blood pressure and it's now 70 over 30, okay? The goal for care for these patients is going to keep them stress-free, manage their PP, and prep them for surgery really, really quickly. We classify them based on where they are. Abdominal aortic aneurysm is obviously more in the abdominal area. Thoracic, that is upper chest. And sometimes patients just have two, and that's really not good. All right, we're talking about coronary artery disease and atherosclerosis. It all pretty much goes hand in hand. Essentially, what happens with coronary artery disease is I have a buildup of plaques in the coronary artery, which causes my coronary artery to become a lot smaller and more narrow. What do arteries do? They supply oxygenated blood to an area. Well, the coronary arteries supply oxygenated blood to my heart so that my heart has enough oxygen and nutrients to keep pumping and keep the body happy. So please keep that in mind. The issue is that when we have narrowing and stretching, this reduces blood flow to the heart, and this puts my patient at risk for a myocardial infarction or a unstable angina episode, because guess what? Angina is chest pain that occurs due to inadequate O2, inadequate oxygen. So our same risk factors for atherosclerosis are going to be our same risk factors for coronary artery disease, because essentially CAD is atherosclerosis of the coronary arteries. Okay, this atherosclerosis occurs from high cholesterol diets, obesity, and smoking. Our main concern is this puts us at risk for clots and reduced blood flow. The clots occur if a plaque bursts and travels somewhere where it no longer fits. All right. Now we've got PAD versus PVD, a little nursing in a nutshell. Some of these slides you'll see at the top, nursing in a nutshell. This means that this topic is going to reappear in your med-surg lectures. So we're not going to get too nitty-gritty because we really need to understand the patho so that next semester when you guys learn about treatments and nursing interventions and patient education, it's a little bit more familiar to you and you'll be more successful in that portion of your course load. So when we're talking about PAD, peripheral artery disease, we are having an issue with our arteries. What do our arteries do? They supply blood, oxygen, and nutrients to wherever they're connected to. So someone has peripheral artery disease, blood, oxygen, and nutrients cannot get down, usually caused by atherosclerosis of the femorals. So our symptoms are going to be pretty much associated with lack of nutrients, lack of blood flow. So you're going to have skinny, cold legs, decreased pulses, thick, brittle skin, thick, brittle toenails, shiny skin, etc. We're going to teach these patients to dangle their legs and limit cholesterol in their diet. These patients also present with intermittent claudication, which is really bad pain when walking. We're going to tell them, when you feel pain, stop, take some deep breaths, and keep walking. That's how we get better. Peripheral venous disease or peripheral vascular disease also called chronic venous insufficiency. Essentially, blood can't return up. This is usually caused by circulatory issues. So our blood is going to pool in the lower extremities. You might see a little bit of varicose veins. You might see some issues. Therefore, we're going to have lots of edema, redness, and swelling in our legs. And our main concern is that they could have a stroke from the blood clots, a VTE, or a pulmonary embolism. So that's just pretty much the basics. I really like this photo at the top. Priority nursing interventions. If they have PVD, we're going to elevate. If we have PAD, we're going to hang. We're going to dangle. All right, we've got Raynaud's versus Berger's disease. I'm probably butchering it, but that's okay. Essentially, what happens with Raynaud's is that my arteries just become very, very constricted at random points, coming white, blue, and red, usually in response to cold weather. Lots of different causes. Some are smoking related, but this is more of a phenomenon. It comes and goes. They'll have this episode, if you will. Berger's disease, on the other hand, this is when we actually have more so like tissue death, poor blood flow, low oxygen, which is more chronic, which leads to essentially necrosis of the fingers, okay? Again, usually caused by smoking, poor diet, etc. But Raynaud's is more of a phenomenon, a situation. It can also occur in patients with rheumatoid arthritis, whereas Berger's disease, we've had some damage to the arteries that supply blood flow to the hands, and we now have some necrosis. All right. Virchow's triad, factors causing VTE. Just remember endothelial injury, stasis of blood flow, and hypercoagulability. The more risk factors these patients have, the more high risk they are, obviously, for getting a VTE, having a stroke, etc. So a hypercoagulable state. Well, we have an increase in like blood viscosity, if you will. Or more blood in our circulation. More common with surgery, trauma, if they've had blood transfusions. Pregnancy is a really, really big one too. Injury, think trauma. Guess what? An IV poke can be trauma. Trauma, when our body gets like poked, any sort of surgeries, things like that, it's going to try to create clots in the area, which is good for that purpose, but again, put you at risk for having a venous thrombosis. And finally, circulatory stasis. Everyone knows that a patient in the hospital is not moving as much as they should. Sometimes because they can't, but more often, just think about it, they're confined to a room. Even if we're sick at home, we're still walking out to the kitchen to grab some water. We're still walking to the mailbox to get mail. We're still walking outside to take the dog out. We're still moving. That really doesn't happen much in the hospital as much as we try. Oops, sorry. But all of that will put you at risk for some of these. When we're talking about thrombosis, we've got a blood clot that forms and will slow down blood flow. We have an embolism, we now have an obstruction, okay? Or we've had a thrombus that has traveled and got stuck somewhere. So when we think embolus, think stuck, okay? We've got venous versus arterial. Obviously, arterial is more of an issue because arteries supply oxygenated blood. So if I have a blockage, I'm not supplying oxygen to an area. That is why we really need to prioritize care, because they can have necrosis if left untreated. Whereas venous issues, we're more concerned about, okay, it's going to dislodge and it's going to get stuck in the lungs. And then we'll have a pulmonary embolism. Alrighty, up next we have lymphedema. Lymphedema is not fluid. We talked a lot about like heart failure and having edema. This really isn't the same thing. we are having an accumulation of lymphatic tissue within soft tissues. Therefore, like our fluid restrictions, our diuretics are not going to work, okay? Meanwhile, they will have non-pitting edema, but it'll be a little bit more scaly as well. What we're going to teach these patients is elevating the extremity, wearing compression garments, things like that. There are possible surgical issues, but remember, this is a lot harder to treat than simple fluid volume overload. Okay. All right, now we get to talk about hypertension. I know there's a lot on this slide. I just thought it'd be a little bit easier for you guys to best understand. Don't worry too much right now about BNP. We talk a lot about BNP and complex health too. I just thought I'd put it there for you guys. But all that BNP does is BNP basically tells the body, I'm stretching. My heart muscles are stretching. The ventricles are stretching, which isn't good because we got to think what's causing stretching. Well, if my patient has high blood pressure, that's going to cause a lot of force and stretching on the ventricles of the heart, and that's not good. That contributes to damage, which will contribute to heart failure. Okay. Another big risk factor for hypertension is our cholesterol. I included the cholesterol panel here for you guys. It's just one of those things you do need to know, you need to memorize because it's going to come up throughout the whole program. What's a healthy cholesterol panel? Remember, we want a high HDL because that is our happy cholesterol, and we want a low LDL because that is our lame cholesterol, our bad cholesterol. So that panel is just here for you guys. Also have the hypertensive crisis. It's kind of when we have over 180, but we're also symptomatic. So this slide kind of breaks it down a little bit more. We've got lots of different risk factors, usually diet, genetic, lifestyle related. Smoking, really big risk factor for high blood pressure. The issue with high blood pressure is this can put you at risk for heart failure, renal problems, renal failure, aneurysms, just a bunch of really bad stuff. When talking about primary, also known as essential hypertension, this is risk factor related. So everything on the top, this is our primary hypertension. We don't really know the cause. We know that it's risk factor related. When I say we don't know the cause, it means I can't pinpoint that your diet caused this or your 10 plus pack day smoking history, whatever. Usually when you see those terms used, it's not necessarily that they don't know the cause, there's lots of risk factors, they can't pinpoint it. So primary, just think risk factor related. Secondary, this is related to something else. We talked about SIADH earlier today. That causes fluid buildup. The more fluid we have in circulation, that's going to contribute to an increase in blood pressure. Okay, we know that it is a cause. So it's high blood pressure secondary to SIADH, meaning the SIADH is what's causing that high blood pressure. We have a definitive diagnosis. We have pregnancy-induced hypertension. We have a definitive diagnosis that is called secondary hypertension. Hypertensive crisis, this is when your blood pressure becomes so elevated that you are now symptomatic. You are having a headache, you are seeing stars, you are lethargic, you have nausea, you have vomiting, etc. And it's really, really high. We've seen blood pressures in the 260s before. It can get pretty bad. But they're usually very, very symptomatic at this point. And it's also based on trends too. Orthostatic hypotension, we learned about this a lot in fundamentals, but this is a drop in blood pressure as the patient stands up. So when they're sitting, their blood pressure will be higher than when they are standing. This is usually related to medications, dehydration, just simply getting up too fast. Our main issue though with orthostatic hypotension is that they are a fall risk. So we need to be keeping these patients safe and sound. Alrighty, now we are heading into our module 5, which is more neurorelated. So when we have hydrocephalus, again, this is really common in our pediatrics. So just think this is more peds related. With hydrocephalus, essentially what happens is in the brain, you've got the suckle, and it's surrounded by CSF fluid, cerebrospinal fluid. What happens with hydrocephalus is we've got either an overproduction of CSF, or my brain simply just not draining enough. This leads to edema and swelling within the skull, causing an increase in intracranial pressure. These little babies will have a high-pitched cry. You'll see that their head simply just looks a lot bigger with bulging fontanelles. Remember, when these babies are dehydrated, you won't have the bulging fontanelles. Bulging fontanelles, we got fluid excess, especially in the head. And then finally, they will have sunset eyes, meaning you will see like a big white sclera over where their pupils are. And they're gonna be crying a lot. Our treatment is going to be to put in a ventro shunt to help drain the fluid. But it's very important that if they have a shunt on the left side, that we don't lay my baby on its left side, because we don't want to occlude the shunt. I want to lay the baby on the right, or put the baby on the tummy, or rotate. Cerebral palsy. This is a neuro disorder that essentially messes with the patient's their muscle and motor control. Again, you'll see this more in pediatrics, children, whatnot, but when you have an infant, they're going to have a lack of head control. Their heads are going to kind of be bobbing around, etc. The debilitations do vary. Some are a little bit more severe than others. It's kind of like a spectrum. But it's very important that with a patient with cerebral palsy, that we elevate their head of bed and keep suction at bedside. Okay, this is we want to increase in ICP, reduce stress. Farm tip for future farm, baclofen does help. But usually with these patients, we're going to see non-specific movement coordination, posture disorders. Okay. All right, meningitis and brain abscesses. So meningitis, really pay lots of attention to the photo on the right. What happens with meningitis is we have inflammation in the meninges caused by a viral or bacterial pathogen. Patient with meningitis will have these signs. If you have a positive Brudinsky or Kernig sign, we know that this patient has meningitis. Please note that a patient with meningitis will be on droplet precautions, and unfortunately, we're going to have to treat with supportive care. Vaccines do help prevent meningitis. They often make, if you plan on living in a college dormitory, they make you get an updated meningitis shot. Something I like to help when I'm trying to figure out, is this Brudinsky's or is this Kernig's? Brudinsky, when we bend the neck, our knees and hips are going to come in. With Kernig's sign, think of like Kermit the Frog laying on their back as you pull the knee in to kind of squat like a frog. They're going to have lots and lots and lots of pain. So that's Kernig's sign. Brudinsky's, their knees are going to bend up. As you bend their neck forward, their knees are going to pull and bend up. Kernig's sign, as you try to get them in that frog little squat, they're going to have lots of pain that's going to prevent you from getting them in that full frog squat. Encephalitis, this is inflammation of the brain, can be caused by viral infection or an autoimmune process. What are we going to do? We're going to treat the underlying cause and provide supportive care to alleviate increased intracranial pressure. What does that look like? We're going to reduce stimulation. We're going to dim the lights. And we also do this for meningitis because we're really just trying to alleviate increased ICP. We're going to dim the lights. We're going to cluster our care. We're not going to bother them. We're going to be very, very quiet. We're not going to ask them 15 million questions. We're not going to bang on the door. So I talked a lot about increased intracranial pressure today. I thought I would just give you guys a little bit of information about what's happening. Essentially, the brain is a closed box. Something has to give. So if I have head trauma from a concussion or an accident, or I'm having CSF fluid building up, it's going to increase the amount of pressure. But remember, the brain is a closed box. So something's got to give. Usually our cerebrospinal fluid will displace first, but if not, we're really, really concerned. Why? The respiratory control center is at our brainstem. If we have so much pressure, it's going to cause things to get squished. We do not want our brainstem to get squished. So you'll start to see confusion, altered level of consciousness, altered respiration, their eyes won't be equal. What we have is called Beck's triad. This is indicative of increased ICP. Patient will have their blood pressure will go up, this Cushing's triad, the blood pressure will go up, their pulse will go down, and their respirations will go down. We hardly ever see this triad happening because usually if we see anything in the hospital, we'll see their blood pressure drop and their pulse will go up. It's very rare you see high blood pressure with a low pulse. It just doesn't happen. Additionally, because of the respiratory control center, you'll also see altered respirations. So we talked about meningitis, we talked about encephalitis, we talked about cerebral palsy, we talked about hydrocephalus. It's very important that we help get treatment because we really need to be preventing increased ICP. All right, now we get to talk about spinal cord injuries. Here, I just have kind of a list of how patients can have spinal cord injuries and whatnot. They're actually quite common. And just note that it's always important that we talk to the patient about their mechanism of injury. What caused this? The reason that we're concerned about more of like our mechanism of injuries because we need to know what might happen. Did we have some rotation? Did we have some shearing? With our older adults, they have fragile spines. We talked about hyperparathyroidism. And with hyperparathyroidism, we really know that it's going to pull calcium from the bones. These patients are going to have fragile spines. Okay. I want you to note that the higher up the injury is on the spine, the more debilitating it's going to be. Remember, we've got our spine, and again, if it's above, our C spine is at the top. And usually when you see like a trauma or if you're watching in shows and they put the C collar on, they're stabilizing C spine, because if there's an injury at C3 or to 1, 2, or 3, these patients do need mechanical ventilation. So just note that the higher up, the more debilitating it is. Okay, it's going to be really important that we maintain airway breathing circulation. We monitor their level of consciousness. We get a spine CT and an MRI, and we do a good neuro assessment on these patients. Okay. Usually care is going to require a multidisciplinary team because these patients can have tetraplegia, quadriplegia, etc. All right, now we get to talk about stroke and more of our vascular neurological disorders. So when we talk about TIA, transient ischemic attack, this is temporary and reversible, usually due to atherosclerosis of the coronary artery, the carotid arteries. Remember, with the coronary arteries, they supply blood flow to the heart. they can contribute to a myocardial infarction. A TIA essentially is the same thing, but now we're talking about the brain. So we have atherosclerosis of the carotid arteries. The carotid arteries supply blood flow to the brain. If I have temporary blockage due to atherosclerosis, I'm going to have temporary reduction in blood flow. This causes a TIA, meaning they will have those like traditional signs and symptoms of a stroke, but it's going to go away and it's reversible. However, if someone has a TIA, they're at big risk for having a CVA in the future. Or CVA, this is an actual stroke. They have reduced blood flow to an area of the brain that is kind of prolonged, whether this be from a brain bleed or a clot. We need to find the underlying cause and treat them. How do we recognize a stroke? We use B fast, balance, eyes, face, arms, speech, and time. With eyes, I'm going to have blurry vision. They're not going to be looking at you very well. Balance issues, coordination issues. Face, ask them to smile. If one side of their mouth is droopy, that can indicate a stroke. Ask them to raise their arms. If one arm kind of falls down while the other one is able to be raised, well, that's also a sign of stroke. So if my patient's left side of their mouth is drooping and their left arm is also drooping, we think that they are having a stroke. Remember, the brain is flipped. So if I'm presenting with symptoms on the left side of my body, the stroke is probably on the right side of the brain, and the brain is flipped. Speech, ask them to say a simple sentence like the sky is blue. If they cannot do that and it sounds garbly or like they've got marbles in their mouth, it's time to call 911. Okay. And brain aneurysm, we talked about more of our aortic aneurysms, but what happens with the brain is that we have an outpouching of a blood vessel in the brain. If this blood vessel bursts, that blood goes out of brain circulation, it leaks into the head, and guess where it's not going? It's not going to the rest of the brain. Essentially, it's like if you've ever tried to drink something out of a straw that has a hole in it, and no matter how hard you try, no fluid's coming up that straw, or very little fluid's coming up that straw, because we've essentially got a leak. That's what aneurysms are. With migraines, these are caused by many different things, such as stress, allergies, cold, low blood sugar, tumors, etc. This slide is pretty lengthy on migraines. Don't focus too much about it. Just note that some patients with migraines, they can have an aura, but regardless, they will have a very bad headache, usually accompanied by photophobia, nausea, vomiting, and a unilateral pulsating pain. Okay, so don't stress too much about this slide. It's got a lot on it. Just note that some have auras and some don't have auras, but no matter what, our nursing care is going to stay the same. What we're going to do is we're going to place them in a cool, calm, quiet, and dark room. We're going to limit stimuli, cluster our care. However, we do become concerned if patients have severe headaches or a new sudden onset, especially in the older adult population. And again, this is just kind of another photo for some of my visual learners. What headaches, what migraines, etc. Again, avoid the triggers and put them in a cool, calm, quiet, and dark room. Again, it's just going to be more comfortable for them. And really, as nurses, it's kind of our job to provide that patient-centered care. Up next, we have seizures and epilepsy. Again, this is a list of all the different types of seizures a patient can have. It's not important to memorize, okay? Just note that seizures may present differently. Our grand mal, tonic-clonic, that's our traditional seizure, stiffening, contraction, what we see on TV, etc. However, note that a patient can also have an absent or a partial seizure where they're kind of just out of it for a minute. Epilepsy, on the other hand, this is chronic unprovoked seizures. It's a chronic condition where patients do have seizures, and it's frequent for them. Okay. If a patient has never had seizures before and they start having a seizure, absolutely we call 911. But if we know the patient has epilepsy, it's just a common reoccurrence for them. No matter what, though, we have what's called status epileptics. Essentially, what happens is if the seizure lasts more than 5 minutes, this is a medical emergency. The reason it's a medical emergency is because when you are seizing, you are using up a lot of oxygen reserves, a lot of energy. So if a patient has been seizing longer than 5 minutes, we are now concerned that there's going to be an issue with adequate oxygenation and tissue perfusion. So if the seizure lasts longer than 5 minutes, we call 911. Okay. Don't worry about the rest on this slide. I really want you guys to focus on the nursing interventions. So we protect them from injury. We make sure that the pad rails are sided. We note the time and the duration. The best thing we can do is we turn the patient on their side. We never, ever, ever restrain them, but turning them on their side will prevent aspiration and help with oxygen. Okay. Never put anything in their mouths, no tongue blades, no nothing. After the seizure, we're going to give them some oxygen, check their sugar. The reason we check their sugar is, like I said, seizures take a lot of energy. They waste a lot of oxygen, sugar, etc. So we really just want to get a good assessment done on these patients. All right. Now we get to talk about multiple sclerosis. I don't know if any of you guys ever watched like Married with Children, but Christina Applegate, she's actually pretty open about it now, but she was diagnosed with MS. And she kind of vlogs and documents what her life is like with it. So in case you were kind of trying to find like a real world example, that's kind of one you can further research and look into. But essentially what happens with multiple sclerosis is an autoimmune disorder. And like I said earlier, autoimmune disorders are characterized by exacerbations and remissions. So our goal is to prevent exacerbations. Because this is an autoimmune issue, we're going to treat with immunosuppressants, okay? Very important to know our hallmark signs and symptoms, which is going to be some urinary retention, Uthoff's sign. Well, what is Uthoff's sign? So Uthoff's sign is a temporary worsening of vision after exertion. So if someone with MS decided to go for a run, they might, after their run, stop and just have really blurry or black vision. Their vision's going to be worse. Okay. Also going to have some perception alterations, especially with like their hands and their feet. You'll see muscle spasms, fatigue, and some mobility issues. All right. Parkinson's, on the other hand, this is not necessarily autoimmune. What we have with Parkinson's is we have way too much acetylcholine and not enough dopamine. Therefore, when we're talking about treatment, we flip, okay? Unfortunately, there is no cure, but we can do things that can kind of help prevent progression. Really hone in on your hallmark signs and symptoms. Your hallmark signs and symptoms are going to include a mask-like blank expression, stooped posture, pill rolling tremors. They'll often have a freezing gait. Well, they'll start walking, they'll do their Parkinson's shuffle, they'll start walking, and then they can't move forward anymore. What we tell these patients to do is we tell them to march. Just march on by, just keep going. Okay. We know that there can be a neuro decline kind of associated with Alzheimer's and dementia. So we really do want to provide a safe environment for these patients. Up next, we have Guillain-Barré syndrome. This is caused by an autoimmune reaction to a trigger. And not necessarily a specific trigger, though. Usually with Guillain-Barré, the patient has some sort of viral infection, their body fights off the infection, but instead of normally fighting off the infection, the body kind of gets triggered into overdrive. They will present with ascending paralysis, really, really bad back pain. Okay. This can progress pretty rapidly. Um, the issue with the ascending paralysis is going to start having paralysis in their lower extremities and it's going to creep upward. The issue is when it creeps all the way up into the lungs, because then they're going to require mechanical ventilation. Okay, they're going to need to be intubated. Treatment is supportive care and IV immunoglobulin to kind of help flush out their autoimmune attack. We always need to assess the patient's heart rate, blood pressure, and airway. Intubation might be necessary. So just really note the ascending paralysis and why we're concerned about airway. Up next, we have Huntington's. This is our autosomal dominant disorder. It's a really big topic for discussion when it comes to family planning. The reason is if someone has Huntington's disease, they have a 50% chance of giving it to their child. And some people just simply don't want to play with those odds. The reason being with Huntington's is usually it's not diagnosed till later in life. But once you receive that initial Huntington's diagnosis, they usually only will live about 5 to 10 years. Why? Essentially, what happens with Huntington's disease is that they have these chorea movements that are just uncontrolled, uncoordinated. They eventually lose their ability to have voluntary movement. Once they stop having voluntary movement, they become pretty confined to bed, wheelchair, etc. The reason that these patients pass away is usually because complications of impaired mobility, like respiratory issues. Same thing we talked about earlier. We want our patients up and out of bed. We want our patients to, do their incentive spirometers, things like that. But if these patients lack controlled motor movements, they're not going to be able to do any of those things. Unfortunately, there is no cure for Huntington's disease, so genetic counseling and end-of-life care planning are imperative. All right, and I believe the last slide I have for you guys is myasthenia gravis. This is MG. It's an acquired chronic autoimmune disease. Essentially, what happens is that we're having an issue with nerve impulses. Essentially the body has kind of messed up its way of, how do I best describe this? Acetylcholine helps trigger movement. So if I say I want to go reach to my right and pick up a cup, that acetylcholine is kind of triggering that motor neuron movement. What happens with MG is that we have an autoimmune attack on the acetylcholine receptors. So if my body produces acetylcholine to activate the receptors to trigger controlled movement, if I can no longer do that because my body has attacked the receptors, I'm going to have a hard time doing controlled skeletal muscle movement. Usually these patients will have issues with their eyes, face, mouth, throat, and neck. And the issue with this is, again, it's an autoimmune disease, so we can manage it pretty well with immunosuppressive therapy, but our issue is that we can have a myasthenic crisis. This is when we do not take our medications as prescribed and we start seeing issues with our heart rate and our blood pressure. This will lead to respiratory distress. with myasthenia gravis. So again, these patients really just have a little bit more of a difficult time doing controlled motor neuron movements. It doesn't necessarily affect mental status, mental health, anything like that. It's just that they might have some issues with controlled movements and especially eye movements as well. Okay. So now I will open it up to questions. If anyone has any questions they'd like to ask me, if you need me to go back to something, I will work on sending you guys a PDF copy of the PowerPoint shortly. I'll also work on uploading a recording for you guys.
Can I send you my email so that you can send it to me?
Yeah, of course. Yeah.
Where should I send it?
You can pop it in the chat if you want.
Manifestations are.
Do you want it in the Zoom chat?
Yeah, you can do the Zoom chat if that works. I'll pull the chat up right now.